Shall we make a start? Yeah. Brilliant. Thank you very much all for coming. My name's Abby Wood. I'm a governor of the Royal Free London and I'm also a Camden councillor. There are a number of other governors here present tonight. Can they wave, stand up, identify themselves in some way? We've got a few here. And I just wanted to highlight our role, which is representing the interests of patients and of the public. And after the formal part of the meeting, if anyone does want to talk with any of the governors, then we'll be staying around afterwards. Events like these are a really important part of how we share the work of the Trust and we keep local members informed. And it's fantastic that the Royal Free has such an active and engaged membership. And I'm really pleased that there's so many people here tonight to hear more about the work that's done by the Trust in terms of caring for pregnant women, for new mothers and for their babies. My day job is working for the National Childbirth Trust, so this is a topic that's really close to my heart. And now I'm going to hand over to Chris Strether, the Group Chief Medical Officer. Chris.
Brilliant, thanks very much, Abby. Thanks very much indeed, Abby. I'm Chris Strether, I'm the Group Chief Medical Officer, and I'm going to speak very, very briefly. You'll be relieved to know. I've only been here for 18 months. But I came here for some very, very positive reasons, and the kind of most important one of those was the innovative work we're trying to do to improve the quality of care through clinical pathway groups, which John and colleagues are going to tell you about in a minute. I'm just going to go through the first couple of slides and then do that. So I think people know this, so we're the 6th largest NHS trust in the UK. We manage at the moment 3 acute hospitals in North London, Chase Farm, Barnet and this one, and we have over 10,000 staff. So more than 1.5 million patients visit us every year. We cover a catchment area, depends how grand we're feeling, of 2.5 million people. And we're a vanguard for acute care collaboration, which is the group model, this kind of small chain of hospitals that we run. The second important thing there is we're a national digital exemplar. So we've had some money from central government to advance our ability to use technology to improve care. And one of the most important aspects of that is to facilitate the development of pathways in the way that John and colleagues are going to tell you in a minute. They'll tell you how brilliant it is, and you'll see it when you're there. But this is attracting quite a lot of attention. I've been to Wolverhampton today to talk about this to some of the people up there. They're doing some very exciting things with general practice there, which I think we could steal and might be able to use locally working with colleagues in general practice. But they were very excited about what we're doing about clinical pathways and reducing the variation in care, which we think is an opportunity to improve quality. So I'm not going to talk for any longer. And I'm going to let John introduce colleagues and talk about the principles of how we're going to go about this.
First of all, thanks everyone for coming and giving us an opportunity to talk about what we're doing. And I'm just going to give you an overview. You're going to hear from the real people who are doing the real work. And that includes our patients, which is the most exciting thing that we can say. So this is the vision for the Royal Free Hospital. And the component of this that we want to talk about today is in the green box, I guess it is, at the bottom, which is in reducing unwarranted variation in clinical practice. And what we believe that we will achieve is that will derive benefits for patients. It'll improve the effectiveness, the quality of the care that we deliver. It'll improve the benefits for staff in that they will be working to deliver stuff in a continuous improvement way, and will help them to work to do the very best for patients, and that we hope that by doing this we will derive great benefit for taxpayers. That's all of us in this room. And eventually, we want to be involved in looking after the whole of population health. So the step after what we're going to talk about today is reaching out into primary care and communities and using this kind of quality improvement and patient co-design to really improve the health of the population that we are here to serve. And when we started this journey, this is an American healthcare system that we formed a partnership with. And for about 30 years, Intermountain Health, which is in Utah in the United States, have been trying to standardize the care that they deliver to their patients across a very large geography, much larger than the UK, but of course a very much more rural geography. And we've learned a lot from them, but we have adapted what they do in the United States to suit our population and our hospitals. So we have a theory behind what we're trying to achieve, and I think it's worthwhile trying to explain it. What we want to do is that we first of all, we believe that unwarranted variation in clinical practice and clinical care leads to worse outcomes for patients, and it is more costly to the healthcare system. And by unwarranted variation, I have a very simple definition of that. It's stuff that, if I was a patient, adds no value to what happens to me when I come here for care. And so we want to reduce that non-value activity, and we want to improve patient outcomes. And we believe that by doing that, reducing the variation in what happens, we will lead to better outcomes for patients, and those outcomes will be defined by patients, not by us, and that will reduce cost to the healthcare system in general. Now, this doesn't mean that we are going to indulge in what some people might call cookbook medicine. What we say is that in the vast majority of cases, patients need the same sort of treatment, the same evidence-based treatment, the best quality treatment. But in some instances, we are very lucky in these hospitals to have fantastic clinical skills. So we have some of the best doctors, nurses, allied health professionals in the NHS, and we ask them to use their professional judgment that when it's best for patients, they veer off the pathways that we are describing. So the way we're organised, just to explain it a little bit, is we have 3 hospitals currently in the group, but in this work, we're actually also working with the North Middlesex Hospital and West Herts Hospital in Watford. So they're also involved in working with us on defining clinical standards. And each of the hospital specialties is organised in divisions, and those divisions work together across all of the hospitals as CPGs, or clinical practice groups, to define what the best possible treatment is, design a pathway that allows patients to be treated in the same way in any hospital that they go to, where they will receive the same excellent outcomes and have the same excellence of care. And that's really what we're trying to achieve. And the good thing about this structure is that everybody who works in this hospital, from the chief executive to the ground floor, which is us, the clinicians, will try to achieve the same thing. So when we came to embark on this, we were slightly daunted because Intermountain Health in the US had been doing this for 30 years, and our task was to try and achieve something similar in 3. And so we had a matrix to try and prioritize what we would work on first. And these are the things that we analyze. So we tried to do things that we did a lot of. So high volume activities. We tried to do things that were low volume, that were highly costly. So for example, a liver transplant or major liver surgery is one of the low volume things, but which is an extraordinarily complex activity that we do in this hospital, and of course do very, very well at a very high international standard. And then we also focused on where are the areas that we can improve our clinical care. So we analysed all of our clinical outcomes, and we said these are the things we really want to achieve and improve on. And those data come from national audits, from local activity that we do to look at what our outcomes are and what we can improve. And very importantly, we looked at what our patients were saying, and looking at those outcomes and saying, what can we do better? And we ended up with this list of pathways, and this was the starting point for this year. So we have 20 clinical pathways that we are standardizing and working through, that every hospital in our group will use the same methodology to deliver care to patients. And today you're going to hear about women's and children's and 2 specific pathways. Now, by pathways, I think it's worth probably defining what I mean by that. And my definition is very clear. It's what happens to a patient and what a patient's perception is of when they come to us looking for treatment for whatever their problem is. So it's not about what suits the hospital. And I think that some of the work we've had to do is deconstructing how we've built up our hospital systems over many years and tried to redesign everything around the needs of the patient. And the theme for tonight is how patients themselves are driving us to rearrange the care that we deliver in the way that they think is most important, not what we think. And that is a major cultural shift in the NHS, but it's one that we found immensely liberating and exciting to be involved with, and we're really proud to be able to talk to you about how we've done that. And we've partnered with an organisation who are represented here today called the Point of Care Foundation, who've helped and trained us in the methodologies and the way of engaging patients in the best possible way to redesign the way our hospital works. So don't worry about this diagram, but it means that we've got a pathway, and a patient is sort of like in a, I don't know what, a computer game, and every time they hit a red box, they're not getting what they want. And what we want to do is take the red boxes out, and we want to make the pathway, the journey through the hospital, the best possible experience for every patient, and they get the right treatment, right time, by the right person. And we end up with a very simplified pathway that we think will make everything work efficiently and will deliver the best possible care. And critically, and the most important thing, and the best decision we made when we started to do this, was to engage in patient co-design. And you're going to hear some wonderful stories, and I'm incredibly grateful for some of our patient co-design, co-developers to take time out from their busy lives, and then you can see how busy they are, to really drive what we're doing. So this is two examples. The top one is from the group that's looking after inflammatory bowel disease, and the bottom is a young girl who has asthma and has had multiple attendances to A&E, and she's helped us redesign what we deliver for young children with asthma across North London. And that actually turns out to be one of the most important public health issues we face in North London. So we end up with a big document that we hide away in the background, but this is really important as we redeliver this, because what we want to do is take it a step further, and we want to move from simply pathways that might be on paper, and we're trying to bring our systems into the digital age. And I will be quite honest with you, we lag behind in the NHS about that. But at the Royal Free, I think we are embarked on an incredibly exciting journey to really make digital health work for patients. So we're not trying to implement systems whereby we all sit in our rooms ignoring who's sitting beside us. We're trying to build this system to deliver what we really need to improve care. And we end up with this sort of thing, and this helps clinicians move everyone through the clinic and to allow them to spend more time dealing with what the patient wants and what their carers want and what their families want, and not focusing on all of the other paraphernalia that actually we spend quite a lot of our times doing. And what we want to achieve eventually is that we will expand clinical practice groups across all of the clinical care that we deliver. And so we are now, over the next 3 years, going to address about 60 clinical pathways, but we will probably cover almost all of the clinical activity that we do in the hospital. That's just a starting point, because we're then going to use the digital information that we have, the engagement with patients through a portal and their feedback to us, to build a process of continuous quality improvement. So these pathways are not fixed in aspect, which is sort of what we have done in the past with clinical guidelines. What we want to do is to continuously improve, continuously innovate, to learn from everything that we are doing in a much more reflective way, and to really drive improvement for patients. So I'm going to hand over to the teams, and Tim Wickham is the lead of the Women's and Children's Clinical Practice Group and the Divisional Director for Women's and Children's, and he's going to give you an overview of what his team have been trying to do.
Thanks, John. Yeah, as John said, I'm Tim Wickham. I'm a consultant paediatrician and chair of our CPG group. I've been a consultant for 15 years, and this is definitely this process that we're involved with here is definitely trumps any other initiatives that I've come across over the last 15 years in terms of a chance of actually really making a difference, really gaining traction, and really making a difference for our patients, and putting the patient right in the middle, not the hospital, not the doctor, not the nurse, the patient. So it's I've got a very nice job tonight, and that's basically to introduce you to the guys that are actually doing this work. And I think we're starting off with Kathy Rogers, who's going to be talking about. We're starting with Shanti. Okay, we're starting with Shanti, who's a consultant neonatologist, and she's going to talk to you about the keeping mothers and babies together. And then following on from that, we're going to have Kathy Rogers, consultant midwife, to talk about better births. So let's hear from Shanti.
Good. Fabulous. I'm Shanti. I'm a neonatal consultant, and I'm working with Rose, who's sat here with me, working on the Keeping Mothers and Babies Together pathway. So just to introduce you to the pathway. So why the Keeping Mothers and Babies Together? This is a graph of deliveries, babies who are born across the UK over the last, well, from 2010 to 2014. And as you can see, the biggest blip is 2012. And since 2012, our deliveries are reducing. We are having fewer babies in this country. The black line that you see is the number of babies who are born at the right time, but who are being admitted to the neonatal unit. Now, we know that we're able to look after more complex babies with more complex medical problems. But actually, even taking that into account, we seem to be admitting more and more babies. So we know we want to practice safe medicine. We want to do the right thing. We want to do the safe thing. But the question we asked ourselves is, are we being too cautious? Are we erring on the side of caution and admitting our babies to the neonatal unit at the expense of families' experience and families' anxiety? So we really wanted to go, okay, what are we doing? And is there a way that we can address this in a safe way? So we started off looking at what we do currently. So we looked at babies who are born at 34 weeks and above, because that's the sort of gestation where we can, all being well, look after mums and babies together on the postnatal ward. And we looked at what happens from the point that we identify a baby is either a little bit premature, or there's complications during the pregnancy that makes it more likely that the baby may have additional needs after birth. And what did we do when we looked after them? And I'm not going to go through the pathway. The one thing that we all looked at this pathway when we drew it up and thought, oh my word, this is really complicated. And then we looked a bit further. So the blue box that you see down here is all the different risk factors that mums or babies had that made them need that extra bit of care, that made them probably end up on our neonatal units. And when we looked at them, so the top one, if you look at sepsis, so infections, and GBS is a bug that can cause infections that can be quite serious in our babies. What we found is that we had slightly different guidelines on how we managed these babies compared to, say, a baby whose mum had diabetes in her pregnancy. Those babies had slightly different things that we did to those babies. And then those babies who were born at 34, 35 weeks, who are 5, 6 weeks premature, we looked after them slightly differently still, all in keeping with national guidelines. So what we were doing is being replicated in every hospital across the country. But what we realised is that we're making it really, really hard for our staff to figure out what to do for which baby and when and how often. And so what we ended up doing, we think, is that by making it so hard for our staff to deliver the right care the first time, we ended up with babies who were with their mums, maybe straight after delivery, to being on a neonatal unit in an incubator. And as a neonatologist, I'll tell you the thing that our families say to us on our neonatal unit time and again, and it's this: it's meeting your baby for the first time in a clear plastic box is probably one of the most frightening experiences of their lives. And it's something, if we can avoid it and safely do that, we need to be doing that. What did we do? Well, we started off by asking parents to fill in a diary, thinking about emotional hotspots. How did it feel if your baby was at slightly higher risk, who needed a little bit of extra care? How did that feel at each point in your journey, from the point of delivery to the point that you identify that baby needs a little bit of increased support to being admitted. And then we also brought our parents back to focus groups to just explore this a little bit further. And I'm going to give you some ideas of what parents said. What rang true to me was how I felt when I had my first baby. She was gorgeous. And I will tell you, for the first 24, 48 hours, all I could do was stare at her. Every little bit of her. And if she cried, she only had to do a whimper before she was in my arms being comforted. And boy, was it hard to have anybody else touch her. Only I could do that. And if you pushed me, maybe my husband, but actually it felt like really, this was my role. This was what I was supposed to be. She was amazing. And reading this, where actually your baby is in a plastic box and lots of strangers are touching your baby and she's crying. And my empty arms are just that, empty and unable to comfort her. If we can avoid that, we need to be doing something. So what do we try and think about, we try and do? We thought, let's make it simple. Let's talk to our staff and try and make it as simple as possible to get the right care, the right time, at the right place, the first time. So we wanted to make it one simple pathway, not those millions different ones for different risk factors. Let's make it simple. Let's make it one thing that we do for all our babies who are at risk of having complications or needing enhanced care, and let's make it standardized as much as possible, so actually it's making it easy for our staff to be able to deliver just that. So we sat down together with families in our focus groups, with our parent, and this is what we came up with: one single pathway from the point that you're pregnant and you can see that there is a possibility that your baby might need enhanced care after delivery, to really focusing on that amazing, precious first hour, thinking about supporting that transition from being inside mum's tummy to outside, thinking about trying to get feeding established, all the way to the point you're going home. And how do we do that? So this is what we did. So each bit of paper that we developed was each bit of that pathway you've just seen. And we produced this, gave it to our staff and go, okay, go ahead, test it, see how it works. And it was an absolute disaster. They looked at these 5 bits of paper and said, you've got to be kidding. This is too complicated. It is not going to work. So we had to go back to the drawing boards. And what we did is pull each bit of paper apart, and we tested one of them several times and got feedback from our staff and from our families. Every test. Changed it, tested it again before we started adding a second one. So this is what our families were saying to us. We got written feedback in forms of feedback the parents could fill in as and when they wished. We had video feedback from families that we used for feeding back not only to ourselves but to our staff, and also just informal one-to-one conversations. And I just wanted to show you a summary of the videos that we've got.
Hello, my name is Priscilla King. I had my baby in Barnet General last year, 2017. I'd like to share with you some of my experience whilst I was in hospital. I've written some of it down, so that would be where I'll be reading. Oscar, my baby, was born by a C-section at 36 weeks. His fluid levels were low and he was breech, so we were advised that it was best to have a C-section. When Oscar was born, the midwives weren't happy with the sound of his breathing. He was sounding a little bit grunty. However, after my checks, we were both sent back to the ward. It was about an hour later that the head paediatrician came and suggested that they take Oscar to the NNU, which is what they did. Obviously, I was very upset because I'd just had my baby for like an hour, and then he was gone. But my main frustration was the fact that I'd had an epidural and therefore my legs were numb still. So I had to wait for the feeling to come back, and as soon as it came back, went down to visit him. I saw him in the incubator and I knew that's where he needed to be, and I felt reassured. Oscar was kept there for 12 hours and then he was given a course of antibiotics for 5 days. After 5 days we were discharged. It was about 2 months after we were discharged, I was pleased to be asked to go back to the hospital and give my views and share my experience in a focus group with some of the staff members. We discussed my thoughts and how to improve the service that patients are given, basically. Various topics, including the orange hat path, were discussed, which I still think is an excellent idea. Most of my thoughts covered patients getting clearer and better information as to what's going on, both before and during the hospital stay, and also, more importantly, after when they go home. This being my first baby, I didn't have a clue what to expect, what to do, and it would have been nice to have a little bit more information and maybe just someone telling me what to do, and then I can just learn. If there was a website maybe also that listed the main questions that patients ask, so any questions they may have regarding anything to do with their newborn, with easy and understandable answers given, rather than just going to Google, because Google can be very scary at times. I think that would be really beneficial to have a website or an app, both for before and after the birth. And my biggest point of all is that the hospital are listening to patients and they're improving the service that they give. I'm so pleased to have been part of this experience and this journey that you're now on, and I wish you all the best for the future. Thank you very much.
Okay. So the orange hat that's mentioned, it's all a part of making it easier. So we've simplified the pathway, but we've also made it easier for our midwives and our paediatricians to identify which babies need that extra support. So the orange hat is to identify those babies. So you can walk into any bay here or at Barnet and look at across 6 to 8 babies who are there and say, actually that baby, and that family need that extra support with feeding, with extra observations, with the monitoring. And we have volunteers everywhere sending us hats, which have been amazing. So one of the amazing things that Priscilla did that she hasn't mentioned was when we touted the idea of orange hats, staff were really worried. They said, well, families are going to feel really stigmatized by wearing these orange hats. They're going to feel odd. And what Priscilla was able to say to our team was, no, that makes me feel special. It makes me feel reassured that you're going to look after me and give me that support. It also means that I won't feel worried about asking for that extra support because I know that's what he needs. And that's been incredibly powerful. So it's nothing that I could have said would have changed our staff mind as much as those few words from Priscilla. So it's been amazing. The one thing we've taken away from her that has been absolutely phenomenal is empowering parents. And it's about giving them information as soon as we possibly can. So we have designed a leaflet. The leaflet actually also has a QR code, which families just use their phones to scan over the code, and it downloads it on their phone. So they have ability to read this at leisure, at their disposal. And they can download that anywhere. So when you're booking in, you're seeing the midwife antenatally, and you're told that you have diabetes associated with your pregnancy, you can download that onto your phone. So you know that when you walk into that delivery suite and have your baby's going to have an orange hat and they're going to have these sort of observations, and this is the support you're going to get. And it's been phenomenal, really well received. And I think the words of families speak for themselves and have really helped us embed the pathway. Staff have really embrace this, both because they feel we're listening to them, because every time they feed back we change the pathway to suit, to make it absolutely right, but also because families are able to say, yeah, we're getting it right. So our staff like them, our families like them, but is it actually making a difference? So this is a chart that shows the rate of admissions for 34 weeks and above. So for example, we had last year just under 9,000 babies born. Of those 9,000, 8.3% were being admitted to the neonatal unit. Okay. We've been testing the pathway. The full pathway only we've put it all together and started using them only in the last 2 months, but already we've seen a drop of 1.8%. That translates on that 9,000 to about 160 families we've kept together and not needed admission to the neonatal unit. And we've carried on checking to see how families feel about the support that they're getting. So we do that once a week, every week. We ask families as part of our safety thermometers, and what they're saying to us without exception is that we're getting it right. The support they're getting after delivery with their babies between the time they deliver and the time they go home is about right. They're feeling confident. So John talked about digitalization. So like I said, this is all on paper at the moment, but we're moving towards all digital. And we have been really lucky to be able to shape what goes on the digital pathway. So the things that we've managed to do that we're quite proud of is the little orange hats. So that on a board where you can see all of the babies, we know which babies need that support. So it's just those little things that we're doing, we're helping our staff to get it right first time. So we have tested the pathway in real time. We're going live in 10 days, but we've tested it beforehand with our staff to see whether it works, and does the digital bit feel clunky? Does it feel alien? And the answer is no. They like it. It's easy. Bring it on. And so what's the next steps for the team? Well, we're going digital in 10 days. It's not, as much as I would say it's easy, we need to be supporting our families and our staff to embed it. And then we're thinking about transition home. So we know that this pathway stops at the point that they're discharged. But I'm telling families, and I'm telling our parents, that they have babies who are slightly more vulnerable. Say, for example, if your baby is 6 weeks premature, your baby is 6 weeks premature for a long time. That makes you anxious. But they're not getting to the neonatal unit. So actually, the team out in the community after discharge don't know all of those anxieties that you've just lived through. So we've already started talking to our GPs and our commissioners about how do we make that communication right? How do we get it right and get it secure so that actually families feel empowered and to know that actually the midwives in the community know exactly what they've been through, and the GP that they're going to see in 2 weeks, 4 weeks, 6 weeks time know exactly what they've been through. So we're now working on that, and we're spreading the learning. So that the picture there is Medway Hospital in Kent, and they have taken one part of our pathway, the respiratory distress aspect, and they're testing that to see whether it works for them as well. And nationally, NHS Improvement, as part of NHS England, are going to take our pathway and make it available for all hospitals across the country. I am one person talking, Rose is here, but actually this is a team, and we cannot do it without absolutely every member of the team, but more importantly, every member of our neonatal and maternity teams across all our sites. Thank you.
Thank you. Good evening, everybody. Lovely to be here this evening, and welcome to the Royal Free. My name's Kathy. I'm a consultant midwife, and like Shanti, I'm part of a huge development group leading on the Better Births pathway. So we've talked about the bit around the baby in that first hour of the baby, but the pathway that I'm talking about covers the whole 10-month journey from when a woman gets pregnant until we transfer her care over into the community. And what I'm going to do this evening is to talk a little bit about the context and why the Better Births pathway and what is Better Births. And the kind of strategies, because as John said, you know, engaging with service users in terms of designing the pathway, identifying the priorities, and helping us to evaluate the pathway has been integral to both the pathway success. And I'll talk a little bit about where we are in terms of success locally and our rating in terms of the national picture, because we're not the only trust in the UK working on this pathway. But I'll give you a little bit of a hint into where we are. We're probably one of the highest in England in terms of our position for delivering what's required of this pathway. So the pathway has meant major transformational change for how midwives, obstetricians and GPs work in terms of delivering a continuity of care model to women. So when women are pregnant, the idea of the pathway is they have a named person who leads and who sees them for 80% of all their antenatal contacts, who's there when they come and have their baby, and who goes out and looks after them postnatally. And I know some of you, looking at you, is a similar age to myself, and it's almost going back to, over the last 30 or 40 years, we've developed a very hospital-focused maternity services. And this pathway is about delivering the majority of maternity care in the community and in hubs where women are, and supporting them when during the birth process, and caring for them postnatally. I'm going to talk about what we've learned, particularly what we've learned in terms of engaging with service users, and a little bit around the power of having the woman's voice at the heart of, and the husband's voice at designing this pathway, and what next. So I won't go through, it's a very busy slide, but this is what we know, is that nationally that we're not getting the maternity, although most women are very satisfied with maternity services. We now know that the evidence is very, very clear that the way we deliver services doesn't best meet outcomes for mothers or outcomes for babies, or is associated with not very good satisfaction level. We know that mothers and babies who are delivered in a more continuity of care model, and who know the people who they're seeing throughout their pregnancy from the national evidence, have much better outcomes in terms of safety outcomes, much less likely for the babies to end up with orange hats, much less likely for the babies to die in pregnancy, much more likely to feel much more competent as mothers, and we know that having a baby is a major transition for families. So the support that's given in continuity of care has been shown to reduce depression, more normal deliveries, less cesarean sections, and by definition for all of those, it's more cost effective for us as a service. But it's a big ask. The Department of Health have said that by March 2019, so next March, that 20%, and Shanti said we had 9,000 babies, we booked 10,000 women to have our babies. We're one of the largest in the sector in terms of maternity services. So we've got to make sure that 20% of our women that book by March 2019 are cared for in a continuity of care model, i.e. they have one or two midwives, a named obstetrician, all of their care antenatally, their care in labour and postnatal care is provided by a team that they know, that they don't meet. For the first time. So it's a massive ask for any maternity. So that's why we call it kind of major transformation. So what we did, I think we started with, we're here because we care. I'm a midwife for the last 40 years because I love giving excellent care to mothers and babies, and that's what drives me, that's what brings me to work. And that's the same for all of my colleagues. We're here because we care. And what mattered to women is probably at the heart, but sometimes we assumed we knew what mattered to women, either by the evidence or by reading CQC reports, etc. But what was really good around this pathway and our other pathways was having our, we know what the evidence says nationally, we know what women have told the Better Births policymakers, we know what our CQC findings are, but midwives on the shop floor that are expected to deliver this pathway, had didn't have the face-to-face. So when we were designing this pathway, the women that were coming were, they could see the faces of what women were said, and that's been really powerful in helping us to embrace the changes that's required. So we looked at our surveys. We looked at the picker survey. We did a survey with women. We did lots of focus groups asking women, our local women, what they wanted. And, you know, the message was very clear. They do not want to see 100 different people throughout the maternity journey. They wanted continuity of carer. They wanted to have a relationship with the people, you know. And I think I liken it to a hairdresser. You know, I've been with the same hairdresser for the last, 30 years. I ain't going to let anybody touch my hair. And you think, well, and we expect women to be okay with anybody looking after them in labour or turning up for all, at the most precious time in their life, And so getting all of that feedback and hearing the views and having the interviews, and we brought the women into the workshops in the room and their husbands to help design the pathway and to look at what we were trying to achieve. And I have to say that has provided the impetus for where we are today, because midwives just thought, well, actually, what you want is what we want. We don't want to come in today and not know who we're going to be seeing. It's lovely having a relationship with our women. So our focus was on when we were doing our interviews, what they said about continuity and in what they said about discontinuity. Their stories, as I've said, were very powerful. And so we were And we had lots of really positive as well as negative stories. So it's not, and that really has helped us driving the change. So what women said when we started was a mixed bag, and I'll just let you read it. And you can see what the women were telling us was very same as what our midwives were telling us, that the best part of their job was continuity and knowing the women that, that they delivered. So hearing the voices of the women that the midwives cared for had a major impact on them wanting to move this forward. So together, we knew what our priority was. I think that's one thing to come in again. Our priority was to look at the pathway, redesign the pathway. I'm not going to show you the kind of various maps and stuff that we did, and to look at what we could do to ensure that every woman had a named midwife, a buddy, an obstetrician to deliver the majority of the care, and as part of a team, be on call for their birth. In terms of our work, we've been working just over 2 years on the pathway. We've done a lot of testing of different things that have worked with our women, with our midwives, so it's very much them working in partnership to make it happen. We've gone from a position of not any women were getting continuity of antenatal, intrapartum and postnatal care to a position now roughly where just coming up to 18% of our women, scaling up much more in December, and really now it's full steam ahead. The part of the evaluation is hearing women's voice, and it's really important to the staff, frontline staff delivering this pathway, is that we are evaluating it, and we've lots of evaluation tools going. And so hearing women's experiences of the pathway has had a profound impact. And women who have been cared for in this pathway have basically said what our Georgetta has said, in that care has been much more personalised. They were able to say when they were not feeling very well, when they were experiencing depression, when, and felt they could trust, they had that trust. So I'm going to introduce Katrina, who is one of our not one of our early women who delivered in this pathway. I hope had a better birth. Come and talk to everybody, and you'll introduce this gorgeous little man.
Initially, my partner and I weren't sure if we were going to come through the NHS for our birthing experience, because I'd had a negative experience with the NHS prior to this, and continuity of care was actually my driving force. Which was really important to me, and that was why we were looking at private institutions for birthing. And our first appointment we were told that we were going to have the same midwife throughout, and that was news to me because nobody I had known prior to my experience had actually had the same midwife throughout their pregnancy. And actually I had heard all the horror stories, because when you're pregnant everyone opens up their horror stories to you. We had an incredible midwife who we've come to love a lot. Sad to be at the end of the process because of our experience with her, and actually she was the reason why we chose to stay in the NHS and actually have our baby at Edgware Birth Centre. For me, I'm not the biggest of fans of hospitals. I have a phobia to them. So I knew that actually having my baby in a hospital might actually cause us complications because of the stress. And the idea of having a baby in a stressful situation, hearing other mothers in labour would put me off. And actually, when my waters broke at 1 o'clock in the morning, we had gone through to the 111 service, who told us to phone our midwife team. And I did, and it was my midwife who was on call that night. So I was again in awe that she heard my voice and recognised me and told me exactly what I needed to do, and we did. And we went over to Barnet Hospital, and being that it was a September baby, they were very busy. And we took the last delivery suite to be monitored for a little while before we went home. And in that process, I could see how stressed the midwives were because there were so many babies being delivered that night. And we were really glad that we were going to go back to our continuity of care programme, because actually our intention was for our midwife to deliver, and luck having it, she did. And that was a phenomenal experience for us. And then on day 2, she also came to visit our baby at home, which made our experience even more magical. And we are decided now that we will have the rest of our children within the NHS, ideally at Edgware Birth Centre, and if our luck continues, with the same midwife as well. But when we have gone for our health visitor appointments, we've also popped in to see our midwife, because she has made such a difference to my experience of the NHS, which actually puts a lot of trust back in it, which I didn't have for a very long time. So that's my experience.
Her story rings resonance with all of the other mums and midwives that are having the privilege to care for women in this model, and that her midwife is looking forward to you having your second baby, she told me today. So I said, hang on there for a little while. So what midwives, this is a big ask for midwives, as well, because it does mean that, that they're having to be on call to be there when the women go into labour. And we were very concerned about that, and midwives initially were very concerned about it. But with the women, we've designed the pathway that's, led to a kind of a work-life balance for the midwife. So during the day, if a named midwife, we wouldn't go have the baby during the day, and I know you had decided you weren't going into labour until Chantel was on duty, but during the day, if the midwife that knows the woman is on, we take her workload so that she can go and care for her woman in labour. And during the night, one of the team midwives come in labour, and on average, midwives have found it just incredible. The words have come there. That's what our women have said, and I think we know how women feel about it, and midwives equally are positive. So what we've learned, that I think one of the most powerful things, when you have your women and husbands and partners and professionals in the same room together, it kind of reminds everybody of why they're in the room and why they become midwives, and it really helps to motivate and drive the change. We know that women can, really tell us what the pathway should look like and what they don't like about the pathway, and have been instrumental in helping us to fix that pathway. They've told us we're a bit dinosaurial in terms of what we expect of them, in that, many of the meetings with the women were them coming to us in rooms, or we going out to our children's centres and meeting groups of women, But using modern technology and blogs and webinars and stuff, you know, when people have young babies, might be something that we need to look to the future if we really, really, truly want to reach out and engage. Women have also said that, you know, having a bit more training and stuff, you know, in co-design work, and our midwives have said the same, that, you know, that because sometimes you can go off the beaten track like I'm probably doing now, and my apologies for that. So basically, what keeping mothers and families at the centre of design implementation pathway, I really believe, and as does the midwives believe, has been the critical thing that's led us to a position of 20%. And in the morning, I know I could get it up to 40% with a little bit more of change with it. So it's been an incredible journey nationally. Most places are at 2%, 3%, with ambitions to getting to 8% and 10%. So definitely, John, we're, what's the word, a vanguard organisation when it comes to maternity care. So our next steps, and it's interesting that we both picked a quote from John Ford, if everyone is moving forward together, then success takes care of itself. And you know, for something like pregnancy and mothering is a journey, you know, unless midwives and women and families and doctors, obstetricians, unless we're working together, we're not going to get it right. And for too long, we've assumed, we thought we were doing the right thing. So keeping the engine of motivation going, so stories like Katrina's and will help us to do that. We have got a maternity service user strategy, but in the strategy, what women ask us for is, you know, travel expenses, if they come, parking expenses, etc., childcare. So I think we need to look at, if we're, you know, to valuing in some way the contribution and the very important contribution service users make to the development of these pathways. We've talked about training and development. You know, the evaluations, the work that's coming through in terms of the impact of the models of care has been phenomenal in terms of patient experience and outcomes. And I think we need to look more at the social media platforms in terms of moving forward with our co-design work for the future. Thank you, everybody.